Hello, I'm Aubrey Gowing. I'm going to show you today some of the assessments, treatment and home care that we teach for rotator cuff injury in our sports massage training course. So, Alison, would you like to join me for a moment? First of all, I'm going to assess the condition. I'm going to do 3 separate tests. I'm going to ask Alison first of all to perform some active movements of the shoulder. So Alison, if you could raise the arm up, straight up as far as is comfortable. Any discomfort on that?
No.
No? Okay. Bring the arm back to neutral. And then I want you to bring the arm into extension. Okay, any discomfort?
No.
No? Back to neutral again. Okay. Then I want you to abduct the arm, just bring it up. Over the head. Any discomfort?
No.
And back to neutral. Okay, so active tests give us general information about the nature and severity of the injury. Alison didn't have any positives there, so we can tell from that there isn't any severe recent trauma to the shoulder. Next I'm going to do passive tests, and this is getting a little bit more specific. Passive tests are going to test passive structures, so they're going to give me information about ligaments, joint capsules, articulating cartilage, and also what I want to look at here is true range of motion and end feel. So once again, I'm going to perform the movement, similar movements, but I'm going to get Alison to relax and I'm going to do the action. So first of all, we're going to go through internal rotation. We want to bring that right around and check true range of motion, which is a little bit limited. And that to me is a little bit jarring on its end feel. So I think there might be a little bit of problem with the inner fascia of the joint capsule. Next, I'm going to check external rotation. Any discomfort?
No. Okay,
and end feel is what I would expect at this joint. It's slightly springy, so this is a soft tissue end feel, and we have full range of motion. Okay. Next, I'm going to do passive abduction. So I'm going to raise Alison's arm up, and I'm expecting 180 degrees. Any discomfort?
No.
Okay. And once again, I have a nice end feel. I have a springy, soft tissue end feel. So we've had no positives, so we can tell that there isn't any severe interfascial restriction within the joint. There isn't any ligament injury to be concerned about. So now I want to test the specific rotator cuff muscles, and although there are 4 muscles, 2 of them do the same thing, so I'll have just 3 resisted tests. Resisted tests are giving me, once again, specific information, but this time they're giving me information about the muscle, its tendon, and its attachment sites. So I'm going to ask Alison to push against the resistance. So I'm going to begin by testing subscapularis. I'm going to bring the muscle to a lengthened position so that I get a strong contraction, and I'm going to ask Alison then to try to swing the arm in. If you try to bring your wrist towards your abdomen, turning the arm in. Any discomfort?
No.
Go a little stronger. Let's make the test a little bit stronger. Any discomfort?
No.
No. Okay, so subscapularis is okay. Next, I'm going to test infraspinatus and teres minor at the same time. So I'm going to ask Alison to push out this time. Any discomfort?
No.
No. Okay. And lastly, I'm going to check probably the most commonly injured of the rotator cuff muscles. I'm going to test supraspinatus. And from the client history, I'm expecting this one to be positive. So I'm going to ask Alison to push out. Any discomfort?
Yes.
Okay, can you point to where you feel that? Okay, and Alison is indicating a specific point, and relax. So this tells me that there is some scar tissue, some disorganized collagen in the area, probably from an old strain injury. If Alison had indicated a more general, broad area, I'd be more inclined to think this is a myofascial dysfunction. So let's move into treatment.
We begin with myofascial techniques applied to the pectoral muscles. Although these are not part of the rotator cuff, when dysfunctional they do contribute to forward shoulder posture. Alleviating myofascial restrictions and trigger points in these often short, tight, facilitated muscles will allow more effective, pain-free treatment of their overstretched, inhibited antagonists. With the client now in a sideline position, we can treat serratus anterior. This will maximize the space between the scapula and the ribs, allowing for pain-free treatment of subscapularis. Passive mobilization of the scapula can now further increase the subscapular space. Subscapularis is now easy to access and treat with myofascial techniques and trigger point therapy. The client is now in a prone position, and we can address the dysfunctional fascial migration patterns that we typically see in the upper back. With the most superficial tissues now released, treatment can progress to releasing the restrictions in infraspinatus with myofascial spreading, cross-fiber friction, neuromuscular therapy, and some localized stretching. Supraspinatus can then be treated with the same multidisciplinary approach. Shown here are just two of the techniques, myofascial spreading and soft tissue release. With the muscle released, the disorganized collagen can now be treated with multidirectional friction, pain-free range of motion, and finally eccentric loading to stimulate the production of functionally aligned, new, healthy collagen. Treatment can then progress to release the adhesion and restriction found in trapezius and rhomboids. Passive mobilization of the scapula is a good finishing technique to ensure that all restrictions have been released and that full range of motion has been restored.
Now, to maintain the effect of treatment, Alison is going to need to do some home care exercises. So I don't like overburdening the client with too many exercises in case they don't remember them, particularly if they're not used to doing stretching or strengthening exercises. So I'm going to do one stretching exercise and one strengthening exercise. I felt that part of the problem was a shortness in pec minor, so I'm going to give Alison a stretch now for pec minor. So Alison, I'm going to get you to bring your hands behind your head. Okay. To stretch pecs, then you're going to bring your elbows back and try to push up towards the ceiling. Now, we're going to follow the work of a pioneer in stretching, a guy called Aaron Mathis, who developed active isolated stretching. And I'm going to get Alison to go back into the stretch, hold for 2 seconds, not bounce, just hold, and then release. Stretching back till we feel a comfortable degree of pull, and then relax. Stretching back again. And this can be repeated 5 times, 10 times, 15 times. If you believe that a stretch should be held for 30 seconds, holding for 2 seconds, multiply that by 15, you've got a 30-second stretch. Okay, that one comfortable? Any problems?
Yes.
Okay, you feel a stretch?
Yes.
Front of the chest? Okay. Next we're going to go on to a strengthening exercise. So you can just rest the arms down by the side. I'm going to demonstrate this for Alison. So I'm using a resistance band, and I'm going to do a strengthening exercise for infraspinalis, which I think will help realign the shoulders and deal with some of that medial rotation on the humerus. So you're going to start off with the band draped across your hands. You're going to reach through and around. And we want to end up with about body width apart. And we're going to do a combination movement. We're going to supinate as we externally rotate. So this is going to be very good for people who spend a lot of time on a desk where they're pronated and medially rotated. This is going to strengthen up the antagonist muscles. So we're going to strengthen up supinator, infraspinalis, and teres minor all at the same time. So I get you to take a band, Alison. Okay, start off with a grip quite wide because it's going to narrow as you roll through. Okay, you're going to bring the fingers towards you, loop through. Okay, now keeping your elbows by your side, I want you to supinate first of all, and then externally rotate, and coming back. Time frames, it's a good idea to give the client an idea of how fast or how slow they should do in the exercise. So we want to come back, we want our eccentric phase to last longer. So if you go out maybe on a count of 2, and then take 3 or 4 to come back, keeping it nice and controlled. So supinate 1 out 2, and then come back 1, 2, 3. Okay, out 1, 2, and back 1, 2, 3. And if we've got the right strength of resistance band, Alison should be able to do this about 8 or 10 times. How's that feel? It's okay?
Yes.
You feel that in the back of the shoulder?
Yes.
Okay. Okay, that's great. And on the next session, I want to check my client's technique, make sure they've been doing those exercises correctly in order to maintain the effects and benefits they've gotten from this treatment.